Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision.
So you've given us several tips. What other tips did you want to share with the gall, like when it's difficult? You said switch to the robot, dome down, trying to get the critical value of safety, putting a Raytech in, suction cautery. What else?
Everyone should have a bailout procedure, and the first thing I tell people is that early on, I thought the bailout was going open my first year. So I was like, oh, this one's taught. You can't do it. And what I realized is it's not an easier surgery just because you're open. It's a different view. You have a feeling that you have more control, but it doesn't necessarily make it easier. And once I realized that, then my conversion rate was much lower, right? What I tell people is it's okay to leave behind a cuff of gallbladder. Typically, you want to leave a drain behind. If it's safer for you to leave behind the cup of the gallbladder, and I always tell people it's better not to sew it over because then they're going to form new stones. Even though you can do both the fenestrating or the reconstituting, but I believe if I'm going to do that, if I can see the cystic duct through the lumen, then I will put a little purse string around the cystic duct. If I can't see it, I just leave the little cup of the gallbladder. I leave a drain behind, and then I talk to my GI, ask him to do an ERC in the stent to try to direct the flow the other way. But sometimes it's okay to not do the whole operation the way we saw it, as long as you are safe and as long as you have the plan as to what you do after the fact. I think in training, we did things to completion. We had our attendings, we had all this other help, and whatever they did, we finished it. And if they got into trouble, they corrected it. In a rural community or even in a community practice, sometimes you may not have all the ancillary support or even the additional surgeons that you need to do these bigger things. And so just make sure when you go in, you sort of thought, well, if this happens, what am I going to do? So that you can just keep on being efficient in your operation.
Mm-hmm. Yeah, that's a great tip. I haven't done that yet. But then again, I haven't done it in Honduras either. I mean, Honduras is the worst gallbladders that I've seen. But it's just something that you got to have some bailout. Now, when you go and try to do that, another question I had sort of written down is, how do you handle lost stones? So if you're going to do a fenestrating cholecystectomy, obviously you're going to be dropping some stones. I have seen what the instrument I call a brontosaurus. It's a 10 millimeter stone picker upper. It opens up like so you like that one? Do you have any other tips for getting stones out?
So I always have my Raytech in there. And so if I know I'm going to open the gallbladder, and sometimes if I've got like so much edema and tissue right around the neck, and I decide to open up the gallbladder anyway, I will put the stones as I'm releasing them onto my Raytech. And then that makes it really easy. I wrap up the Raytech like a taco and throw it into my same bag that I'm going to pull out my gallbladder. But sometimes that'll help me direct the flow also, because what I'll do is I'll get into the gallbladder, as I'm bringing it down, I'll actually open it up sometimes, evacuate the stones, and look and see where my cystic duct is, and then see whether or not I can see where it's coming out from. And then that helps me because I know where it's safe to dissect. So that it lets me do a little bit more of my anterior dissection without me being afraid of I can't bluntly get through this tissue right now. It's so thick. But I know the cystic duct's back here. I can take this front part probably pretty easily.
Yeah. One of my resident mentors told me there's no glory in a lap chole. So they're very hard sometimes cases, but even if you did it, I was like, oh, ho hum. The other thing that I do, we don't need to talk about this because I've talked about it many times on other shows, is laparoscopic common bile duct exploration. So I don't have GI and I don't have ERCP at my facility, and I do routine cholangiograms. And the reason I do that is because we don't have that much volume. And so I want my team to be able to do it when I need to do it. And then I have a choledocoscope that I have now successfully. It's about once every 4 months or so, clear the bile duct, and they don't need the ERCP afterwards. They had stones, whether we knew it or didn't know it ahead of time. Sometimes I go knowing there's there's common bile duct stones, having imaging proving it, and this is my planned operation is a single stage lap chole with lap common bile duct exploration. Successful, then they don't require any transfer. But even when you do those cases, was leading with is the no glory and the lap chole, patient will come back and they'll be like, yeah, Dr. Lehman took my gallbladder out. They don't understand really how bad it was and what you did. It's just say, oh yeah, took my gallbladder out.
Totally. And I tell everyone, like, I used to do routine cholangiograms for the exact same reason. I didn't want my staff to struggle when we actually had to do it. I found out I was the only one that was doing routine cholangiograms. So about 5 years ago, I stopped doing them routine anyway. We finally got better GI support. We still don't have them on the weekends and in the evenings. It just makes it quicker now for my team because we have a lot of turnover of staff. And so you're constantly training the next new person. And after a while, you're just like, okay, let me just make it as easy as possible.
Yeah. Two more questions for that. So I was going to ask you this earlier, but how many cases, what is call for you? Like how many cases do you normally expect to do?
It's variable. Down here, we typically take 1 week of call at a time. So we each take a 7-day block. On a busy week, I'll probably do about 20 cases. On a non-busy week, probably average like maybe 5 or 6. I was on call 3 weeks ago, and, did 6 on-call cases starting at 5 o'clock at night until they were all done. So it's sort of hit or miss. Yeah. The days of like operating all night, which we thought would never happen again after residency, I still probably get maybe like 1 time a month.
Yeah. You said there are 2 main hospitals. Does the other hospital not have call?
No, they have call too. So,
but you're not in that call pool.
No, when I first came here, I put myself on both call pools. I thought that was the best way to learn the PCPs and the ER physicians. Yeah. I found it exhausting. So after about 5 years of doing that, and then both hospitals now had successfully been able to recruit additional surgeons, I decided to just take call at my main hospital.
Could you be on call at both hospitals at the same time, or was that extra weeks?
It was extra weeks. It's for us in general, we highly discourage in this community because there's 2 hospitals in this community that are about 15 miles apart. So it's not that it's hard, but if you are in the OR at the other hospital and emergency comes in, unlike other places where there's somebody else you can call in, like down here on the weekends, all the other surgeons are gone. They're on vacation. I'm literally the only one here, and there's one up at the other hospital. And so sometimes if something comes in and they need help, we might call each other over to help each other out. But then we're like, we get our own, emergency. We're like, okay, got to go now. We got our own emergency. So I think it would be a little too risky because we might be in the wrong spot at the wrong time.
What's the catchment area?
So each of the towns in this county only has anywhere from like 6 to 15,000 people. My city is the county seat, and that our city has about 50,000. So if you took all 10 of the different cities in this county that separated out from every other area by 150 miles or more, it's about 150,000. So what's interesting is we meet the criteria of rural for state. We do not meet the criteria of rural for federal, but living here and working here, we're rural.
Yeah. Well, there's different types of rural. I mean, there's, and the quote I love, and I've said so many times is, you can either do carotids or C-sections, but not both. Yeah. So you're either in a rural place where you're doing really broad spectrum general surgery. And if you wanted to, you could do pancreas or esophagus or liver or vascular, maybe, or but you still have OBGYN and ortho and ENT and plastics and GI, maybe IR. Or you're so rural that it's you and some family practice docs and that's it. And there's no OBGYN and none of that stuff. But then of course, in those environments, you're not going to be doing carotids or esophagus or pancreas or things like that, which is where I've chosen to be. Like you're saying the towns are so small. They're between 6 and 15,000 or whatever. And, my county is, 12,000. The town is 1,500. Right? Okay. But then the other surrounding counties, they all sort of have their little county hospital, and 3 of the 4 don't have call at all anymore. Only one of them has call, and call for me, we take also a week at a time, is 1 to 2 cases per week. And it's usually like an esophageal food impaction. That'd be my number one most common case on call. We have probably 2 appies per month, probably 1 or 2 emergency gallbladders per month. but we're on call also for ovarian torsion and for esophageal food impaction, so even more rural, but there's just a difference.
Totally
Now,
different.
do you have IR?
Intermittently. Some weeks we do, some weeks we don't. Some weeks we have it for one day. We never have it at the night or weekends. It's very inconsistent. It's I've asked the hospital to please make it the highest priority. They're going through a recruitment phase right now. And I'm like, it really changes what we do because we get a lot of perforated diverticulitis and perforated appendicitis at nighttime. And if I don't have IR that can help me put a drain in, and they're not responding to antibiotics, they all get a laparoscopic washout. I'm like, and so I'm trying to explain to the hospital, and they understand it. It's just radiology and anesthesia are two of the most difficult areas to recruit right now because there aren't enough of them. So we're looking. So if anyone knows of anyone, send them our way.
Right. Yeah. I mean, and we transfer for the most part those patients, and then that's a loss too. But what is the name of the county that you're in?
Imperial.
And are you? Is the other hospital as busy on call as your hospital is?
They're a little less busy than we are. So when I used to take call up there, my weeks at the El Centro Hospital were much busier than my weeks at Pioneers. But it's sort of hit or miss. We find that the higher acuity cases a lot of times come to our hospital. So I see a lot of perforated diverticulitis. I see a lot of perforated appendix. I see these really horrible gallbladders. I see a lot of strangulated hernias where I've had to do bowel resections because they waited so long before they came in. And then they're all morbidly obese with a BMI over 40, and I just recently did a strangulated hernia on someone with a BMI of 60. And I was like, I hope we can extubate them. And he did great. But these are the things that typically come into a rural hospital where there aren't enough primary care providers and the patients just wait a really long time. And a lot of times until they're passing out from the pain before they come to the hospital.
Yeah. I just quick looked up Imperial County's 179,000 total.
And more people now.
The reason I'm diving into this so specifically is as I try to learn and be the expert and potentially be the consultant for rural hospitals and help nationally to keep rural hospitals open, which I think a large part of doing that is to keep surgery close to home in the hospital if we can, and how we can safely do that, how we can basically keep the surgeons out there and support them so that they can choose to do that. It's a very complex thing. But one thing is, what is the need for emergency general surgery, since that's our topic? And I have heard that it's 1 out of 100 ER visits is going to need a surgical consult. And so then I'm thinking about that at some of my places that I'm at where there's like 4,000 or 10,000 ER visits per year at the different locations. They're very low. Those are low numbers. That's about as low of an ER as you can get is 4,000. Do we need 40 emergency cases a year? Yeah. But for us, we're doing about maybe 60 emergency cases a year, I would say, which, like I said, about one a week, a little bit over. But we're doing the GI, the GI bleeds, usually the GI bleeds that weren't like really unstable. We still don't usually do because they're going to need ICU and we don't have it. But, the GI bleed that wasn't, we do a lot of those. And then the esophageal food impactions and stuff. So in your case, you got, population 179. Do you know how many ER visits per year you have?
Our hospital, so both hospitals see about the same number of ER patients. Our ER volume is about 100 to 140 patients a day.
Mm-hmm.
So, that's how many patients come through the ER.
Yeah. And so you're talking about 100 per day. So that would be like 30 to 35 to probably 50, somewhere in that range, 1,000 visits a year. And you said you're thinking maybe
between 5 and 20 per week.
So like say 500 cases a year, maybe.
Yeah.
So that's like one for every, like 73 to 100, you're in that range of maybe 1% to 2% needing a consult. So you could then, we could go to a rural hospital who's trying to put general surgery services or whatever and say, like, you can kind of expect to capture 1% to 2% of your total ER volume. That's going to lead to a surgical emergency, basically. I just wanted to walk through the math, so appreciate you going down that with me. Very good. What other stuff so in terms of taking the gallbladder out, we're back on that. You put it in a bag and you take it out, that epigastric just slightly off midline. And is there anything else special when you close up that port? Do you close it or do you leave it open?
Yeah, I close any port so the rule of thumb is if it's 1 centimeter or larger, I close it. So the 12 millimeter trocars, I close 10 millimeter trocars. If I'm using an 8 millimeter trocar for the robot, but I'm doing a lot of torquing around it, then I will close those also. And then for me, because I'm superstitious, I close anything below any trocar that's been placed below the umbilicus. I had one case of a Richter's hernia that I just wasn't expecting from an 8 millimeter trocar where the knuckle just got stuck in the trocar opening. And so now anything below, I'm just like, gravity falls. I'm just going to close all those now. All you need is one time. What? I close it with a suture passer. So I use a WEC suture passer. I don't like the cones and all those other things. So it just is a suture passer. I make sure I get a good fascial bite. I tend to do figure of 8 so that I get a real nice closure of it. And then I always inject that because that's the one where the patients are going to complain that it hurts because now you've got a suture that's through the fascia.
Yeah. And I hate closing the suture passer through the rectus because I feel like you can create even just if you're using a vicryl for that.
I am.
O-vicryl?
Zero vicryl, yes.
So even if it's an O-vicryl, it's going to go away. Like to me, I'm thinking I'm going to take my anterior fascia and stitch it to my posterior fascia, and the muscle is going to be split in that area. And even after it scars down, it's going to have like a scar there. So first off, I don't use any 8s because I don't have a robot. So it's either a Hassan or it's a 5 for me. And in residency, and I'm not saying what I do is right or wrong. I'm just having a conversation here. So 5s are free was the quote from residency. So if you need it, put it. The only time I put a off midline 12 is when I'm doing intentionally, and when I'm doing hiatal hernias, I put it in the left upper quadrant. And so what I've moved to do, because I used to stitch those either with a suture passer or, I'm going to stitch them up and open, and I'm thinking about how to do it. And I would put sometimes the stay stitches. But what I've moved to doing is I just stitch the anterior fascia closed because I don't want to close it to that posterior fascia. Then technically I'm leaving that posterior fascia and peritoneum and everything open, but hoping I don't get a Richter's hernia, I guess, but there's nothing for it to push up against.
Sure.
And so tell me how I'm thinking about that wrong, I guess.
So it's not wrong. It's how you do it, right? So one of the societies that I'm a part of, and I try to go to their conference, if not every year, at least every other year, is the American Hernia Society. It's fascinating. I actually like to go to specialty conferences because now you have everyone who does just that, talking about just that. So I feel like you get a lot of information. So I like going to the American Breast Society, conferences. And so after going to them, and maybe I drank the Kool-Aid, I don't know, but after listening to how they talk about where you're making your holes and why, and as they look at how the incidence of hernias and hernia recurrences and re-recurrences and how it all starts. And knowing that, we're not the only ones who get in the belly. You've got your urologist, you've got your OB-GYN, you've got all these other subspecialties who also go in the belly, and they're not going to these hernia conferences because we're the only ones that fix the hernia despite who puts the hole in there. The idea that most of the holes that you make in the midline will ultimately become either a nidus for a hernia or start becoming a hernia, and how once that starts, you might get in a thin, healthy patient a repair that lasts them their entire life. The reality of it is the majority of them will come back requiring additional repairs, with each one getting subsequently more difficult. And so my thinking, and it's funny because it's not just me, like independently, like a lot of the other general surgeons in my community, we really avoid putting anything in the midline as a result of that. We realize it hurts more going through the muscle, exactly what you're saying, because you're fusing the anterior and posterior together when you're doing that in the middle of the rectus. But you're also less likely to get a hernia because of all the supporting musculature around that area. And just the other day, I got called into the operating room not the operating room. I got called for a consult for someone who had a laparoscopic surgery by a gynecologist a month ago and already had formed a hernia at the epigastric site where they had put one of their trocars. And it wasn't a difficult surgery, but now I had to take the patient back to the operating room to pull out the omentum and close the hole. And so I think
but that's a dehiscence, really, not a hernia.
Really, truly, yeah. But part of it was he didn't close it because he thought it was a small enough, And so I feel like avoiding the midline where we think it's free because we're like, oh, there's nothing else there, it's just fascia, but realizing that fascia should be really respected a lot more than I have in the past. That's what's really changed my thinking. And what I realize in medicine in general is certain things go in a straight line, but most things go back and forth in a pendulum. Perfect example is how to handle reflux disease between medicine and surgery and what kind. It goes back and forth every 10 years as far as the recommendation. So I think right now, as we see obesity increase and we see hernias increase, that the Hernia Society and the hernia experts are trying to create new dogma about how to treat the midline. And who knows, 20 years from now, whether or not that will be still, and I won't be practicing at that point. So.
Right. Yeah. I would like to ask you just a couple. I love tricks and tips and slick moves and things like that. And so I was always on the lookout for that and writing them down in a notebook through residency. And I was just wondering, do you have any slick tips or tricks, kind of like you described for us for gallbladder, for appies or for anything else acute care, abdominal, like, for example, small bowel obstruction or anything like that?
I should have been prepared for this question.
I have one you could think for a second on the appies. And I may say it and you'll say never do that, and that's fine. But the trick for me for an appy is once you identify the base and you get through, first off, always take the base first and don't mess with the mesentery is what I do. I mean, I know other people, they just chomp down with the harmonic and they take the mesentery with the harmonic and then they're left with it and then staple it off. But that's not the way I do it. I take both with the staple load for the most part. And I get the base, and then when I get my Maryland is what I'm using all the way through, I leave it there, or I'll kind of hold the appendix and kind of stretch it up and down parallel to the vessels. And then I get my second instrument alongside parallel to my Maryland and do a anterior posterior spread. And that solves all the fussing and makes it so easy for me to get my staple load. And then, of course, I bring the thin load in down, and it is virtually always easy. Folks that have criticized me for doing that say that you'll get into bleeding. It's when you go parallel to the vessels, it hasn't really been much of a problem for me. So that's like maybe not everybody knows it trick that I could share. Do you have anything else like that? Or if you don't, that's fine.
Yes. Okay. So there's an instrument that I brought down to my community that I had used in residency. And I thought it was something that everyone used and no one down here had seen it before. And after I brought it down here, within months, I had to ask them to buy a couple other ones because they kept disappearing. It's called a laparoscopic finger. I don't know if you've ever seen it. So it's this long instrument. And on the end, it almost looks like a curved spatula that you can do this with. And so if you're doing straight lap, and especially if you've got adhesions and you don't want to sit there with a peanut or Kittner, or you don't want to use a Raytac, it allows you to bluntly do this with it versus striking through it. It has saved my butt multiple times in a perforated diverticulitis and trying to get those adhesions off the pelvis, trying to get to where the ureter is. And so it's called the laparoscopic finger. And so if you don't have one, they always know where it is. And half the time, especially when you're looking at the pelvic sidewall and trying to get the adhesions off the side, or if there's just a bunch of gunk in there, it lets you just go through just like your finger would and just sort of push things around without throwing a lot of other stuff in there. So that's probably the tool that a lot of people didn't know about that I thought everyone did. The other thing I would say with that is I think it's sort of interesting. And one of the things that I appreciate is, and again, I think it's because in training, all my attendings did things such different ways that I always tell everyone, do it the way you want to and you're comfortable doing, but know the other way to do it. So I actually do my appies however it presents to myself. So if it presents to myself where the appendix is sitting straight up and I see the mesentery, I use a harmonic, take down the mesentery to the base. If it's retrocecal and it's a mess, I do exactly what you do. I dissect off where the base is first. I leave the mesentery alone. I find my window and staple across and then go backwards. So I think that the key is always know a different way to do it in case the way that you want to do it every single time isn't going to work that one time. And then I think that gives you a little bit of comfort too, where you're not sitting there going, oh my gosh, what the heck do I do next? Because that then can get a little bit, scary when you're in the OR.
Yep. I love it. Well, I'm being long-winded, and I really appreciate this. Is an incredible opportunity. I just appreciate all your time doing this, but we probably, for the sake of time, should move on to the financial corner. Okay. If you had a money tip for our listener, we'd love to hear it.
Couple things, actually. The first thing, and it's not necessarily a money tip, but it sort of is. Everyone should get disability insurance, but they should specify own occupation. And I didn't understand how many people don't get counseled that when they graduate med school and go into residency. The difference between own occupation versus regular disability versus I actually met someone recently who had no disability because they had never been counseled that. I know, right? You spend literally over $250,000 to train here and then you don't have a backup plan. Own disability means that if you can't, so I'm as a general surgeon, if I can't do general surgery, it doesn't matter that I can go do a job doing wound care or utilization review. My disability pays me out for the fact that I can't do general surgery. I can still use my brain and my knowledge and my experience to do something else in medicine, but the thing that I've been trained highly to do, you're still going to get your disability for that. It costs more to get that way, but I highly recommend. It's so worth it if anything were to happen to you. So that's number one, to be very specific about the type of disability.
How do you know when you don't need insurance anymore? Like, for example, if say you're 62 and you could retire, you have enough financially to retire, right, and you're still healthy and you still like your job and you still like working, would you recommend for that person to have disability insurance? I would probably not. I would probably cancel it at that point.
I would cancel it. I would say that when you're at the point where if you're working because you enjoy it, not because you need to pay the bills, and that if you were to retire right now, you could live off what you already have saved, I think that's the perfect time to get rid of disability.
And a lot of the disability policies only pay till 65, right? So you may find yourself in that situation at 54. Right. You could retire, you're good, and then they're making money off your policy, right? So the chances 100%. Are that you're not going to get, and the quote I love is you only insure against something that would be financial catastrophe. That's why you don't buy the insurance on your TV, because who cares? But if you're super in debt and you've over leveraged on your car and you're losing your car, like I don't have I have only liability policy on my car. I don't have full coverage, right? Because it wouldn't be financial catastrophe if I totaled my car. I could just buy another one.
Exactly. Okay. So that would be one. The second thing, it's sort of interesting. Everyone will have their idea of how best to start out. So I had one friend from medical school who right after residency, he moved in with his parents for 3 years, paid no rent, didn't take a single vacation, didn't buy a car, and literally paid off all his loans in 3 years. And now he has a house, a car, a plane. So he has all his money because he didn't have to pay all the interest payments. There's no way I could ever move back home with my parents. So that was just not an option for me. Other people will tell you, don't make your first big purchase because you're going to have, and I'm sure everyone on your program has said this, we literally go from getting paid fast food worker wages as a resident to getting paid more money than we've seen before unless we had really, really wealthy parents. And so sometimes that's dizzying. It's like, what do you do with it all? Right. And then you come back to earth, you realize you still have to pay your med school loans. You still have to pay your disability insurance. You still have to pay your malpractice insurance and things start adding up. So the thing I tell people is whether you are a saver or a spender, whether or not you're looking to enjoy it now or save it to make sure you have to enjoy it later, make a budget. I was so surprised at how many physicians are like, I've got this money, and they don't really look and see what you need and what you should put away and put in a high risk investment because you have time, what you should put away for your pension plan because we don't, unless you're a W-2 employee, we don't have a retirement plan. And most of us aren't going to be able to survive our lifestyles on Social Security when we're done, and so it's budget out what you think you need. And no judgment. If you really need that Porsche, I'm not going to tell you not to buy it. I'm just going to tell you you're not going to get other things if you pay for that. If you could, maybe get a Hyundai instead, you're probably going to have a little extra money. And so I don't like to tell people like how they should do it based on like what I and other people know, because we're all going to do. I'm sure all of us had advice from someone to tell us to do something, and we didn't follow all of it. One thing that was important to me, because I went to a really expensive med school, was to put a bulk of my relocation and my signing bonus and my loan repayment bonus went to make a huge bulk payment on my loans. And then after I made the bulk payment, I'm like, okay, now I'm going to take 20 years to pay it off. And it's going to be a lot, but I understand that. But I love to travel. And I think if I had like not budgeted money for me to travel, I'd just be in a job that I love, but sort of miserable when I wasn't working. And I really do think work-life integration at some level, everyone's different, is really, really important. But if you spend a little bit less when you first see it and then realize what you need to maintain and sustain, I think it makes sense. So maybe like wait 6 months before jumping into any huge purchases, look and see what it looks like and what is sustainable and also comfortable. Because as physicians, I'm surprised that there are some that literally live paycheck to paycheck. And that's a little sad to me.
Yeah. You can have anything you want, just can't have everything you want.
Yes.
And work-life integration, I like that word. So
yeah.
Thank you. Do you have a personal surgery story that is just classic rural surgery that you'd like to discuss yet?
Oh, absolutely. So, I thought about this one and then it came in 2 weeks ago. I was like, yeah, this is definitely the one. So, being in a rural community, a lot of the patients don't see their doctors regularly. And like I said, in my community, we have a lot of diabetes, we have a lot of obesity, and we have a lot of comorbid conditions. And so hernias here, a lot of people don't take care of them. Meaning they don't tell their PCP, they don't go to PCP, they don't get referred to a surgeon. So I see a lot of incarcerated hernias that I either manually reduce and watch them to make sure everything's okay, or they have to go to the operating room because they can't reduce it. So that's like a typical case. So a patient came in, he was my BMI of 60. And I was like, how? And they're like, he's really short. I was like, oh, okay. He had an inguinal scrotal hernia. So the hernia literally came down. You could see it underneath his boxers. His scrotum was hanging down, probably like 2/3 down his leg. The ER doctor had already tried to reduce it, had given him fentanyl, morphine, everything. And he's like in pain and it's exquisitely tender. I go there, I can reduce. And when you hear that gurgling of the bowel as you're reducing, so I reduce about half of it and then it's stuck. And I'm like, okay, he needs to go to the operating room. We go to the operating room and I hook it up to the robot because I figure if I have to do a bowel resection, I want to try to do it laparoscopically if I can. So we get the robot ready. I'm fortunate to have one. And we go in and I've got my scrub tech, because my scrub teching me at night on the outside. I tell them how to put the pressure on the ring, not just on the scrotum, so you can help. And I'm on the inside and it's all purple. And I'm just like that sinking sensation. And so we reduce the whole thing and it's all purple. And I was like, I'm just going to start my dissection for this inguinal hernia right now. Whether I'm going to just do a suture because I can't put mesh if it doesn't perk up, or if it perks up, I can put the mesh in and we're done. And so I start my dissection. I pull out the hernia sac. I get my, I get it all reduced. The hernia sac was really, really long. And by the time I had done that portion of it had been about 30, 40 minutes, look back, and now instead of being all purple, it's purple, pink, patchy. So I think it's going to survive. And so at that point, then didn't do the bowel resection. There was no abscess because it had been acutely incarcerated, even though he had had it for a long time. It just recently gotten this bad. So I ended up doing a formal hernia repair. I ended up washing out the belly completely. I kept him on antibiotics and he did great and went home.
Wow. That's incredible.
There's other times though when I haven't been so lucky and we go in there, we're like, yeah, we have to do a bowel resection and forget the robot. Let's just open up because this is a mess. And then when that happens, because we see a lot of incarcerated inguinal hernias down here, is I always make sure at the very minimum I at least put a purse string around the peritoneum and the omentum or the fat that's around the hernia. I'm not going to do a formal repair and I'm not going to violate the tissue planes because I'm going to do a bowel resection. But I want to make sure there's not this huge wide gaping hole that all the bowel's going to go right back into as soon as I'm done. And when I find that with those patients, I always offer them a repair later on. And some of them are like, oh, I feel fine. I'll come back to you when I'm in trouble. I was like, okay, hopefully not in the emergency room again.
Oh, man. They don't know, but that's all right.
Yeah.
And if you would do those repair subsequently, then you would come back with the robot?
I do. I learned how to do straight laparoscopic transabdominal peritoneal repair in residency. And I did that for the first 6 years I was in this community before we got our first robot. It's just so much easier and faster. And so now I do all my TAP repairs with the robot.
Yeah, I'm doing a TAP as well, straight stick. But then, I just do that for recurrence or bilateral. And then I just mostly do open if it's unilateral on a man. If it's a woman, I do TAP then. But, there's relative indications and contraindications. The person asks me for laparoscopic, I always just do a lap too. So very good.
And I still do opens. I just had a patient the other week who had an open left and so wanted to open right. So like I said, I think it's great that general surgeons keep all the different tools in the tool chest, and you should be able to change your approach if that's what's indicated. If someone had a history of prostate cancer with radiation, there's no way I would attempt a laparoscopic repair. I just don't want to get into that kind of scar tissue. So those patients would automatically get an open no matter what they want.
Let me ask you a question. Have you ever heard of somebody doing an open inguinal hernia repair and then immediately placing ports and doing a laparoscopic repair in a sandwich technique?
No, I have seen people start off laparoscopic, get stuck, open it up, and then go back to laparoscopic. I've seen, and I'm just like, well, if once you open, why don't you just finish it that way? But
Right.
No judgment. But I've never seen the other way. So they start as an open, then put in the port. But what are they trying to do preperitoneally? Are they trying to reduce the hernia sac completely, or are they worried about adhesions?
Well, let me give you the scenario would be like patient is an elective large inguinoscrotal hernia.
Okay.
And the pre-op note says, because it's so big, I'm going to do surgery, open, fix it, put the mesh, open,
Okay.
then still to reinforce it, go in laparoscopically and do a whole laparoscopic repair and put a piece of mesh inside the abdomen.
The pre-peritoneal mesh, and then they have an onlay mesh.
Yes, 2 pieces of mesh, yes.
I've never heard of that.
Yeah, me neither. Just saying,
I'd be curious, like, if that was something that they adopted or someone actually is training people to do it that way.
No.
I've never heard that before.
Yeah, I think it's made up.
Okay.
All right, very good. Resources for the busy rural surgeon. That was the last segment before we get out of here. Did you have anything that the rural surgeon should just for sure know about?
2 things. The advice I give to rural surgeons, the people who do it, the first thing is I think it's important to go to conferences because it's very easy to get isolated. And that's one way to network, but also to make sure that what you're doing is still standard of care. So I do think that it's very easy to stop going to conferences. You're busy. You don't have it costs money. It's time away from your practice and families. But I think that's really important. But for me, with online and social media, I actually get a lot of benefit. And I wrote the names down for 2 groups in particular. One is for people who do hernias, the International Hernia Collaboration is phenomenal. It's a Facebook group. It is multi-country, not just the U.S. All the great hernia leaders, everyone from Todd Henneford to Urian Novitsky to Dias, David Chen, they're all on there, and they are not only showing videos of what they do, they are very, very generous in their feedback, and the whole hernia community and all the surgeons that are on it, you can post your video and show people or ask questions about things, and then people contribute. And sometimes you like all the contributions, and sometimes there's arguments on there. But it's a way. I tend to be a lurker. I've never posted a video, but I will frequently go through there, especially if I'm going to do a hernia, to sort of see what people are saying and doing and seeing if there's any tips or tricks that they have. So I think that's really helpful. There's another one that's for women only, but it's called Women in Rural Surgery. And it's also a group on Facebook. And so sometimes I'll go on there, and again, people will talk about interesting cases that they've seen, or, they'll ask the question like, hey, I'm about to do this, any concepts and thoughts? And I find that's a way to make your networking even broader. These are not necessarily people that you know, but people, and you're going to get full range, right? Just like with anything, you're going to have people who are phenomenal and experts in their field, and you get people where you're like, maybe we don't want to do that. But it gives you exposure to what a lot of people are doing and thinking and seeing. And I think that it's, being a rural surgeon, you need to know where to look, what on YouTube you're going to go look for your videos. Because, like, for example, there's a huge controversy right now with people who do like very advanced techniques for abdominal wall reconstruction, especially like the robotars and the ETAP procedures. It was a huge New York Times article. Cleveland Clinic was involved. A lot of the hernia people got really upset with it. And what the thing you see is, if you don't know what's good or bad, and you just go on like YouTube or go on some random, you may be learning things that maybe shouldn't be done. And so I feel like going through these curated sites, whether it's ACS or SAGES, because I know they also have their channels and they put a lot of content from the conferences on there. I think that's a really great resource for people who aren't doing it, in these big areas where you have tons of mentors and research going on around.
Right. Yeah, I love it. Well, that is very helpful. Thank you so much for those specific tips. and mostly for coming on the show and taking your time to just share the experience that you've had with our listener. So I really appreciate it.
Thank you so much for having me. And your stories are incredible. It's funny, I never thought that this is what I wanted to do. So definitely wasn't one of those people that was like, hey, I definitely want to go and do rural surgery. But it was sort of interesting because I knew I always wanted to do medical mission work. And so what I loved, especially now that, I'm meeting people who want to do rural surgery and I'm talking to people because I've been doing it for so long now, I find it's fascinating. It's also really uplifting. I find I learn, even 20 years out, I still learn so much from talking to other people. So this has been such a pleasure for me.
Yeah. Well, thank you very much. We appreciate it for sure. And thank you also to the listener for joining us for this episode of the Rural American Surgeon. We will see you on the next episode.